Today, just to finish off today, this presentation will be in two parts. First of all, my colleagues Bronwyn Evans and Carol Allison, who also have had about 25 years in the opioid treatment program field, will be giving you an insight, just an overview, just briefly into what it's like to come on to the OTP, the opioid treatment program, and just one client's journey. So over to Bronwyn and Carol.
Okay, so we've got a story about because we work in the methadone unit in the OTP clinic part, and we had a client turn up and he just touched everybody's heart in Riverlands. And his name is Raymond T. And he's new to the area, and he's arrived at Riverlands on an emergency temporary transfer, methadone Suboxone transfer to our clinic. He's interviewed by a caring nurse for his OTP intake, and he must tell of his drug history, child risk, domestic violence. This is a learning curve for all of you people. This is what happens. The nurse hears of his early childhood abuse, and he's living within a dysfunctional family. And this is pretty well true how it does happen, this story here. Look, when he was young, he got mixed up with the wrong crowd in his teens, and he declined into drug use to escape his recent adult relationships, and he was become the victim of domestic violence himself. He's given the Riverlands OTP info pack and the treatment agreement, which he must read and sign because he's got to know what he's getting in for. The agreement outlines his responsibilities while he's in treatment: appointments, service rules, urine testing, takeaway doses, treatment plans, it's all there. Ray's last dose from his previous clinic is confirmed, and he commences at our Riverlands methadone clinic for dosing. He finds himself in a little small flat with only the bare necessities, as you can see. He's doing well on the program, he's no missed days. Look, he's a model client, his urines are clean, he comes to case management appointments and the doctors. And at case management at Riverlands, you know, he talks to the nurse about dose suitability, because we're getting right into case management now for our clients. His general health, his well-being, his employment, education prospects. You know, yeah, that's pretty well case management. And we can refer to other services if we need to. He's become a model client in the time that he's been with us, and he's encouraged to move out to a pharmacy to dose, where he's eligible for some takeaways. But he must attend a doctor's appointments, must come back for case management reviews. We keep an eye on him. We regularly phone the pharmacy to check out how they're going. Now more stable and feeling a little bit good about himself, he wrongly believes that some days he doesn't actually need his full dose, and he starts to accumulate some takeaway doses, and he decides to do a little bit of dabbling on the street for a bit of this and a bit of that, and by doing this he does manage to obtain some fine luxuries for himself. Now, for clients dosing at the pharmacies, when they come to the doctor's appointment, you know, they've got to provide a urine, and he's done this heaps of times before, but this one isn't looking so good at all. It's triaged straight away, and it's dirty. He's told by the doctor, you've lost your takeaways and you're dosing back here at Riverlands now until you clean up your act. He leaves a little bit angry and he's a bit upset. He's now dosing at Riverlands against his will, and he's not a happy bear. Raymond has gained an attitude. And he's asked by the nurse, hey, lift your sunnies because I need to see your eyes. That's part of standard procedure when you're dosing. He fumbles with his glasses, he drops them. The nurse goes, hang on, you've got some pinpoint pupils there, and your speech is a little bit slow. And he is finding it a little bit hard to comprehend. He's a bit slow himself. No, look, we can't dose you, no way. You're intoxicated. But why not? I haven't had anything else. You might have heard that story from some people. Look, it's our duty of care not to dose you at this present time for your own safety. Duty of care. He leaves the dosing chamber. He's a little bit confused. He's not knowing what to do. He fronts at the reception desk. He's slightly angry and threatening. I want to be dosed and I want my takeaways, and it's my right. He's reminded of the treatment agreement, responsibilities and rules, and he's told to calm down or security is going to be called. So security is alerted because Raymond is escorted from the premises. Now listen, mate, pull your head in and don't get your fur all ruffled. Not a good look. Now, you've got to leave. Later in the afternoon, he returns to come back to see if he can dose, and he apologises, but no, Raymond, you were out of control. You threatened the staff with scissors, and you begin a letter regarding your continuing treatment here. He's given his warning letter and he storms off up the street. He said, stuff 'em, I don't need this bloody program. I can do it on my own and in my own way. I've got my friends. I can handle my addiction. A few days later, and he's feeling not so good and his fur's a little bit manky and tangled. He meets his friends in the park and they're in a similar predicament, out of it, and they don't look so good. They manage to get some gear and he joins them in cocktail drugs and alcohol, and they continue to drown their sorry state of sorrows to inebriation and oblivion. He doesn't recall much of the previous evening. He finds himself waking up in strange surroundings. He's not knowing where he is or what he's done. And he feels a little bit of warm fur to the left of him. He glances down and he's not alone. Oh my God, what have I done? Oh my God, what did I take? He can't remember a thing. A wave of despair overrolls him and he realises he's out of control. He's sick to the core of his stuffing and he runs to the loo and deposits some of his fear. He's now desperate for cash and he takes a job driving for his mate. It's not explained to him very well, and unfortunately then he hears some sirens and sees the blue lights. His mate's scarpering off down the road and he realises this is not the job he should have taken. But Raymond's left with some explaining to do. His story doesn't deal with the police. He's taken into custody. His legal representative refers him to Merit, which is the magistrate's early referral into treatment, which is at Riverlands, for assessment. He's now on bail. He attends the Merit office for his assessment, and upon his assessment he's told Merit is voluntary. But he would be in his best interest to see a caseworker. He does, and he begins to see that life of crime is not where he wants to end up at. He comes out of the interview assessment and realises that he could end up in jail, and no, I'm a young good-looking bear. I don't want to go to jail, and I can't go to jail. He's escorted to court, but he's so scared. Sick to the stuffing, he can barely stand up and he needs assistance up the stairs. Part of the Merit and court conditions are that he'll have to attend counselling and possible detox. It's Easy Intake worker at Riverlands and she takes a drug history assessment. She's very moved by his sad life story. She clutches his little paw tenderly and she recommends a detox inpatient admission and books him in for the next day. And at detox, the nursing assessment, rules, regulations, the doctor does his bit with his vital signs and medical history, what drugs, how long, any absences from using drugs, and checks for injection sites. All clients, but not just Raymond, to check thoroughly, and he's barely embarrassed by the whole procedure. First night in detox, feeling sad and lonely, and his little fur's all clammy and sticky. He realises he's got to make it through this detox and he's got to get his life back on track, and he finally drifts off to sleep. The staff are caring and Comfort Plus is a big priority, and they're always ready to listen and listen and listen day and night. Part of the treatment involves attending groups, and one of the counselling, one-on-one counselling, discharge planning, is all involved in the Riverlands detox, and there's always help and support for people wishing to access it. He begins to feel a little bit better both physically and mentally, and his fur has regained its gloss, and he begins to realise he can beat this monkey on his back. And on day 6 he graduates detox with a positive outlook. He can get his life back on track. Raymond re-engages with OTP, first dosing at the clinic and then with proven reliability and clean urines and the doctor's appointments and case management appointments, he's transferred back out to a community pharmacy. Now he's really stable. He really is quite stable, and he applies for jobs. He lands a casual one with the local council, but not what he pictured. He needs to be a little bit more active. So he moves on to a construction company, still casual, and he finds he's got some time to study. And at the local library he sees some courses available at TAFE. He decides to apply for the business studies in one of the courses, and he meets a delightful young lady, Vanilla. Their relationship blooms and he now has a commitment to study hard. He's reviewed by his doctor, and based on his stability, Raymond is now suitable for a shared care arrangement, which Ray will tell you more about soon. Now, a few years later, Raymond is now a successful businessman and he devotes his time to his wife and family, and he also gives his time speaking to the young people, advising them on the perils of excessive drug use and alcohol. And in his youth, Raymond made choices that weren't always suitable or best, but life is a learning experience and the road we travel can be bumpy. And travelling through the roundabout of life, we need to think of which exit we should take, because we all have choices. And that was our little story.
Thank you, Carol and Bronwyn. That's one way to look at someone's experience in OTP, what actually happens. As I said, I'm the NUM at Riverlands in Lismore. We're a methadone Suboxone dosing centre. This talk today is primarily aimed at GPs. It's also broad enough to give some others in the field just an overview of what happens with opioid treatment programs and the process and the journey, if you like. Just to give you just some fast facts about opioid treatment programs in Australia and where we're at. These are 2014 figures, Australian Institute of Health and Welfare. Currently 447 in Australia on opioid treatment program. In New South Wales has by far the highest proportion, 26 in every 1,000 people, 26,000 people. And for the Northern New South Wales Local Health District, which for these figures, 808, that includes Richmond and Clarence, 808, and at Riverlands we manage 374. Of the breakdown in New South Wales for clients on the program, 68% on methadone and buprenorphine Suboxone, the other 32%. 1 in 10 clients are from Aboriginal and Torres Strait Islander background, which is way over representation. And the average age is 40 and increasing. And that's been the trend in the last few years, usually increasing by about 1 year or so. That may be attributable to the fact that quite a number of our referrals are from people in their 40s and 50s who perhaps have never injected in their lives, and they have long-term chronic pain issues, and they've been managed by their GPs on Oxycontin or prescription opioids, and their GP has said, well, look, no, you need to look at a longer program. We're no longer prepared to prescribe for you these medications. And of course, with breakdown of clients, 2/3 male, 1/3 female, which is about the proportion for people who are coming into withdrawal services as well. Just in the local health district in this particular area, we have public clinics at Riverlands, at Lismore, Nimbin, which is an outpost, and Clarence and Grafton and Tweed Heads. Just historically, and particularly up here in the last 2 or 3 years, we've had the problem of reaching capacity as far as services are concerned. We're full with long-term stable clients, many of whom have been stabilised and no longer complex, and this prevents new clients from getting on to the program. At Riverlands we have about approximately 100 referrals every year from clients who self-refer or from GPs who are wanting to come on the program, but the number of people who discharge themselves or transfer is nowhere near that number. So waiting lists are a fact of life. It's just unfortunate that waiting lists have to occur, and sometimes we have to prioritise, and we do. Waiting lists in New South Wales, I think the worst I've heard about, or the longest I've heard about, has been 12 to 18 months in some sections of Western Sydney, and the Hunter New England region, it can be several months as well. Rather than put these measures into place, we've looked at what we can do as a service to try to, if you like, free up spaces for new clients to come on, and so that there's a flow, if you like, of clients coming in and out of the clinic. This is part of a move where public clinics seem to be more like acute stabilisation centres. That we have the expertise, the skills and the knowledge, we have the addiction specialists. We should be looking after and maintaining and managing the more acute, the more complex clients, and that clients who have been in treatment for quite some time and who are stable should be managed in primary care. We'd love primary care. We'll bring that up again, particularly with GPs. So, when we talk about stable and unstable clients, usually we've categorised all of our clients into categories 1, 2 and 3. And it's category 1, the high needs, to remain in public clinics and to have specialist treatment and consultation and closer follow-up and more frequent reviews. Category 2, moderate needs, perhaps primary care with specialist support. And for as the ones I mentioned before, low needs, long-term stable, no significant issues, they can be easily managed in primary care. Now, when I talk about stability, the ones that are managed in the low needs, managed in primary care, these are the people who they attend the clinic regularly. They present well. They don't miss doses. There's no diversion. They have clean urines, and the urines show a pattern of reduced or nil use at all. There's no benzo use involved, and their social functioning is improving, partly most probably because they're on the program. And there's no current mental health issues, and of course transferring to a GP is voluntary. The patient doesn't want to be dosed at a public clinic anymore. As part of our role at the clinics, identify these particular clients and say, well, look, congratulations, it's time for us to part ways. You've graduated, you're too good for us now. It's time to move on to community GP land, and it's for some people who have been there 8, 10 years or more, it's quite a self-esteem boosting thing. And this is a way we've been able to, as I said, free up spaces on the clinic so that we can bring into the clinic people who are acute, complex needs, who need to be on a program. We know that opioid treatment program, for some people it's a life-saving intervention, and it's certainly we do like to prioritise clients who are in acute need, such as clients who are pregnant, current mental health issues, recent overdoses, recently discharged from prison, and so forth. They're our, if you like, our core business. But I'll just move on. We were talking before about the journey. The destination isn't, and the end destination is not the public clinic. Ideally, people come into a clinic, and after a while, after a period of stabilisation, they can go to a community pharmacy where they'll get takeaways and a degree of more freedom and less intrusive. And then eventually, after a while, if they're deemed to be more stable and stability continues, they can go to a GP prescriber. It's about treatment matching, having people being treated in the right setting. For example, if someone with mild depression would not be appropriate to be treated with a clinical psychiatrist. We're talking about people who are perhaps already linked in with their GP long-term basis and see the GP for physical or other ailments on a regular basis, and they could easily, the GP could easily monitor and manage their pharmacotherapy treatment. It's about normalising the treatment. It's not special treatment, it's just a long-term part of this person's management and care and part of their rehabilitation. Now, once the client's been identified and discussions have taken place and they are agreeable and the GP has been approached and they're agreeable and the pharmacy has been approached and yes, everything is okay, it's a bit like settlement day on a property. Everything has to gel, everything has to coordinate on the one day. There's a bit of documentation to complete, and that's done by the GP and the client together. And we will liaise with the GP and the client and pharmacist to put this all together. We'll sort it out. We will organise it. What the GP have, their responsibilities and their just components of care is, of course, writing a script every 3 months. That's minimum 3-month clinical review and urine screen as clinically indicated. And of course, when they're going to a GP, we just don't at the clinic at Riverlands wipe our hands of them. There is a shared care. We actually do provide ongoing support from the clinic, such as transfers to interstate, stability reviews and dosing reviews. So if the client wants to go up and down on their dose or takeaways reviewed and the GP would like a second opinion, they can always come back to the clinic for that. I think David mentioned before about the 7 a.m. to 11 a.m. consultation service. That's all part of tied in with this. We also, if the client does become at any stage unstable or the GP wants to transfer them back to the clinic for any reason, that's fine, that's our responsibility, we always do that. And that has happened on 1 or 2 occasions in the last year or so. As with any treatment, particularly with this client group, honesty and transparency and being upfront about clinical decisions, and the decisions have to be based on observation and clinical judgment. Of course, provide access to good quality care, and importantly, prescribe methadone, buprenorphine and safe, sensible prescribing that you're comfortable with. And if you're not comfortable with it, again, pick up the phone and we can provide access to one of our addiction specialists. Review the patient regularly and assure safe provision of takeaways, which is very important at every consultation to remind clients of the safe storage of takeaways. And of course, liaise with the pharmacy regularly before each script. They see the client several times a week and they have a better idea about how they're going. And of course, give a copy of any care plan to the patient and organise cover, if necessary, when you go on leave, annual leave, or particularly if you retire. Currently, GPs can have up to 5 clients without completing an online accreditation course if they come from an already accredited prescriber. But those provisions will be changing with the new New South Wales state guidelines for opioid-dependent clients, and I believe it will be going up to 10, is that right, David? 10 later in the year. And part of this whole process has been the formulation of a process with Medicare Local. There'll be a clinical pathway that's currently being developed, which any GP can look up in the region. And that should be finalised, I guess, hopefully June June perhaps? Okay. That's... Thank you for listening. Thank you.